Good morning. I'm Dr. Saisham, consultant surgical gastroenterologist. I'll be speaking about the esophagus today. Today, we'll be dealing regarding the anatomy, that is, the surgical anatomy of the esophagus and the various investigations to investigate the various diseases in the esophagus. Moving on to surgical anatomy. Esophagus is a muscular tube approximately measuring about 25 centimeters in length in the adult. It occupies the posterior mediastinum. It extends from the upper esophageal sphincter to the junction with the cardia of the stomach. It extends from the lower border of the cricoid cartilage and the sixth vertical vertebra and passes anterior to the vertebral column through the superior and posterior mediastina, passes through the diaphragm at the level of the 10th thoracic vertebra and ends at the level of the 11th thoracic vertebra. It is the second narrowest part of the alimentary canal following the appendix. It has three constrictions, namely starting from the incisors uh, at 15 centimeters and at 23 centimeters when it is crossed anteriorly by the aortic arch, and at 28 centimeters when it is crossed by the left principal bronchus, and at the level of the diaphragm, which is at 40 centimeters. The musculature of the upper esophagus and the upper esophageal sphincter is striated, followed by a transition zone of both striated and smooth muscles, with the smooth muscle portion progressively increasing in thickness. It is lined by squamous epithelium throughout. The parasympathetic nerve supply is mediated by the branches of the vagus nerve that has synaptic connections to the myenteric plexus, which is the Auerbach's plexus. Meissner's submucosal plexus is sparse in the esophagus. The upper esophageal sphincter is made up of striated muscle. The lower esophageal sphincter is just above the esophagogastric junction. Embryological development. The esophagus is developed from the part of the foregut between the pharynx and the stomach and from the posterior pharyngeal hindgut. It is at first short but elongates with the formation of the neck, with the descent of the diaphragm, and with the enlargement of the pleural cavities. The musculature of the esophagus is derived from the mesenchyme surrounding the foregut. Around the upper two-thirds of the esophagus, the mesenchyme forms striated muscle. Around the lower one-third, the muscle is formed by smooth muscles. Moving on to the arterial supply, the cervical esophagus is supplied by the inferior thyroid artery, the thoracic aorta, the bronchial and esophageal branches of the thoracic aorta. Four or five esophageal branches arise from the anterior surface of the thoracic aorta. They form a vascular chain and anastomose with the esophageal branches of the inferior thyroid artery and the ascending branches of the left phrenic and left gastric arteries. Moving on to venous drainage. The small venules arise from the esophagus, form a submucosal plexus, which then join together to form a periesophageal venous plexus, which form esophageal veins and which drain into the thoracic esophagus, predominantly into the azygous vein, lesser extent into the hemizygous vein, intercostal and bronchial veins. The venous drainage of the cervical esophagus is from the inferior thyroid veins. These veins meet with the left gastric veins at the lower esophageal veins at the esophageal opening in the lesser curvature. Lymphatic drainage. There are multiple longitudinal continuous submucosal lymphatic channels which drain from the cervical esophagus to the deep cervical nodes or through the paratracheal nodes. Vessels from thoracic esophagus drain to the posterior mediastinal nodes, and lymphatic vessels from the abdominal esophagus drain to the left gastric lymph nodes, and some pass directly to the thoracic duct. Location and description. The cervical esophagus, and these are the various relations of the cervical esophagus, and in the next slide I'll be speaking about the various relations of the thoracic esophagus. The cervical esophagus anteriorly has the trachea, the recurrent laryngeal nerve, which ascend on each side in the groove between the trachea and the esophagus, which is a tracheoesophageal groove. Posteriorly, it is bound by the prevertebral layer of the deep cervical fascia, the longus colli, and the vertebral column. Laterally, on each side lies the lobe of the thyroid and the carotid sheet. Moving on to the thoracic esophagus, it is situated to the left in the superior mediastinum in between the trachea and the vertebral column. It passes behind and to the right side of the arch of the aorta and then enters the posterior mediastinum along the right side of the descending aorta. Then it crosses anterior to the aorta and enters into the abdomen through the diaphragm at the level of the 10th thoracic vertebra. Anteriorly, from above downwards, the trachea, the right pulmonary artery, the left principal bronchus, pericardium, and the diaphragm. Posteriorly, the vertebral column, longus colli, right posterior intercostal arteries, thoracic duct, azygous vein, terminal part of the hemiazygous veins and accessory hemiazygous vein, and aorta near the diaphragm. To the left of the esophagus, in the superior mediastinum, the terminal part of the aortic arch, left subclavian artery, thoracic duct, left pleura, and the recurrent laryngeal nerve are present. And then moving on to the posterior mediastinum, the descending thoracic aorta and the left pleura are present. The right lateral relations are namely the right pleura and the azygous vein. Moving on to the investigations. First, we'll move on from basic to the highest level of investigations. Radiography, contrast radiography. What is contrast radiography? It is nothing but a barium swallow which must be tailored according to the needs and the suspected diagnosis. It demonstrates the various changes in the esophageal diameter, anatomical distortion, or abnormal motility. A solid bolus is used in a motility disorder, which is followed by a video recording of the barium swallow to demonstrate the motility disorder and in the diagnosis of the particular motility disorder. Barium swallow is not an accurate diagnosis for gastroesophageal reflux unless there is very gross gastroesophageal reflux disorder. CT has a better accuracy in terms of diagnosis of various esophageal disorders pertaining to the changes in the diameter and anatomical distortion. The diagram on the right shows the normal barium swallow and the numbers 1 and 2 indicate the normal constrictions in the esophagus, 1 being the indentation from the arch of the aorta and 2 being the indentation from the left principal bronchus. The first diagram over here shows a foreign body in the upper thoracic esophagus, and the second shows a barium swallow of a patient with an impacted food bolus preventing the flow of barium bolus further down. Again, these are barium swallows of carcinoma of the esophagus. The first diagram showing an apple core lesion, and the second X-ray shows a bird beak appearance with a sigmoid esophagus suggestive of a long-standing achalasia cardia. Moving on to endoscopy. It can be both diagnostic and therapeutic. It is required to view the inside of the esophagus and the esophagogastric junction. A diagnosis can be performed. Diagnostic procedures such as biopsy or cytological specimen in case of carcinoma esophagus can be performed using an endoscopy. The various therapeutic procedures that can be performed by endoscopy are dilatation of an esophageal stricture, banding or injection sclerotherapy for esophageal varices, endoscopic removal of foreign body, and endoscopic management of esophageal perforation. There are two types of endoscopes, mainly the rigid esophagoscope and the flexible video endoscope. The rigid esophagoscope is obsolete and is no more in use. The pictures on the right are of a normal person, wherein the first diagram is the picture of a normal esophagus and the second of a normal gastroesophageal junction. Here, the first picture shows a proliferative growth in the mid-thoracic esophagus, and the second one shows the endoscopic view of an patient with achalasia cardia with a pinpoint gastroesophageal junction opening and a dilated and distended distal esophagus, which might be a sigmoid esophagus. Moving on to endosonography. Endoscopic ultrasonography relies on high-frequency transducer located at the tip of the endoscope to provide highly detailed images of the layers of the esophageal wall and mediastinal structures close to the esophagus. It might be of two types: radial echoendoscopes, wherein the ultrasound probe looks at the surrounding structures in circular pattern, and linear echoendoscopes, which looks at the lesion in a head-on pattern. The diagram below shows the various layers of the esophagus in a radial echoendoscope. Layer 1 being the mucosa, layer 2 being the deep mucosa, layer and the muscularis mucosa, layer 3 being the submucosa, layer 4 being the muscularis propria, and the last layer being the serosa. Esophageal manometry is used to differentiate between different types of motility disorders of the esophagus. A 24-hour pH and combined pH impedance recording. Prolonged measurement of the pH is the most accepted method for the diagnosis of gastroesophageal reflux at present. It is useful in patients with atypical reflux symptoms without any endoscopic evidence of reflux esophagitis and absence of response to intensive medical therapy, which might include proton pump inhibitors. It is useful in the diagnosis of non-reflux esophageal disease. How is it performed? A pH probe is placed 5 cm above the lower esophageal sphincter endoscopically. How do you confirm the position of the lower esophageal sphincter? It is confirmed by manometry. And the values of pH less than 4 is measured over 24 hours. A normal person, an adult, is said to have less than 4% of measurements of less than 4 pH. And then later they are graded based on different classifications, and management might either be medical or surgical. Moving on to the highest level of investigation, which is the CT of the thorax with oral contrast. In malignancy, it is the gold standard for the diagnosis and management of carcinoma of the esophagus. It gives a complete picture of the various relationships of the esophagus with the surrounding structures. It also shows us the spread of disease and the nodal status of the carcinoma. The operability of the disease with respect to relationship and local invasion of the surrounding structures can clearly be made out with a CT of the thorax with an oral contrast. Management of esophageal perforation. It shows us the site of perforation and the size can be determined by a CT with an oral contrast, and it can also be used for the management of an esophageal perforation, wherein you can place multiple drainage tubes into the pleural cavity, wherein there is collection of contaminated fluid due to the esophageal perforation, for example in case of Bohr-Heels syndrome. The picture on the right shows a cross section of the thorax at the level of the inferior pulmonary veins. Thank you. Tomorrow in the next class, we'll be speaking about the various causes of dysphagia, the various investigations to investigate a patient with dysphagia, and the management of dysphagia.